Hey guys, this is Jeremiah. I'm at the Richmond station. This is a short little video primer on how to use our new Impact Eagle vents. They got a few more bells and whistles than our auto vents, so let's get started. Also, I'd like to talk to you a little bit about, give you some insight on management of the ventilator patient so you can be more comfortable next time you have to transport a patient that's intubated on a ventilator. So let's get started. First of all, we're going to use our ventilator circuit, and when you're pulling the ventilator circuit out of the package, it's important to make sure these two tubes are connected to the patient end of the ventilator circuit. This is the pressure transducer tube. This is the exhalation port tube. They only fit one way. The nibs are different sizes and they only fit one way. Just make sure they're connected. Step 2. We're going to connect the ventilator circuit up to the ventilator. So we're going to connect the big corrugated tubing up to the gas out or to patient. Next thing we're going to do is we're going to take those two little hoses. There's our pressure transducer. If you notice, it's green and the nib is green. So we're going to hook it up. And then finally we're going to hook up the exhalation valve. They only go one way, so you can't mess them up. Including your ventilator, you're going to have a little this is called a Tessalon. It's a simulated patient lung. It simulates the resistance and give of a real lung, so you can test your ventilator circuit before you put it on a patient. So we're going to take the Tessalon and we're going to put it on the patient end of the ventilator circuit, just like that. Okay. We're all hooked up. Normally, I have this thing, we're using room air. It actually has its own compressor and it'll deliver 21% oxygen. So for demonstration purposes, this is what we're going to use today. But normally, you have a green high pressure hose. You're going to screw it in there where it says oxygen in, and that's going to go to your oxygen tank with your regulator on the high pressure port, just like the auto vent. Alright, so let's turn this thing on. So first thing we're going to do is if you'll notice, all these knobs are labeled 1, 2, 3, 4, and 5. So we're going to come over here to step 1. We're going to actually turn the ventilator on, and we have to calibrate this pressure sensor. So we're going to start it up in cal mode. It says cal mode, and then it says OK. So the ventilator is now calibrated and ready to use. So the first, we're going to start this ventilator up, and we're going to set it up, and we're going to set it up in AC mode. And I'm going to explain more to you about what AC mode means. So let's set it up in AC mode. Alright, so we've done step 1. Alright, let's move on to step 2, which is the ventilation rate, or how many breaths per minute the ventilator is going to deliver. And if you can see right now, it's set for 12 breaths a minute. If you can zoom in on that. Alright, cool. So we're going to, just to show you how the knobs work, we're going to set it for 16 breaths a minute. They're very sensitive, so you have just small touches, if you can see there. So now we're set at 16 breaths a minute. Step 3, we're going to set the inspiratory-expiratory ratio. I'll go into a little bit about that later. But the IDE time, pretty muchly, for all our transports is always going to be 1 to 2. And if you move the IDE knob all the way over into the far counterclockwise position, right there, it'll always come up in 1 to 2. Step 4, we're going to set the tidal volume. This is the amount of air that the ventilator is going to deliver to the patient in one respiration. Right now you can see it's set for 550 and it's delivering. It'll show you what it delivers. It delivered 546 milliliters. So we're going to set this tidal volume to 600 just so you can see it working. If you can see, I barely touched the knob. So these knobs are really sensitive. They're going to be hard for you to adjust when you're transporting. Last thing, one of the final steps is step 5, and that's our FiO2, or percentage oxygen, that the patient's going to get. Right now we're using room air, and we're using the internal compressor on the ventilator, so it's telling me it's delivering 21%. You'll notice if I try to increase the FiO2, the ventilator alarms. So let's reset that alarm, dial it back to 21%. Okay, last step, but not least, is the PEEP, or positive end expiratory pressure. Positive end expiratory pressure is the air pressure that's left in your alveoli after you fully exhale a breath. Normal physiologic PEEP is 5 centimeters of water. So after you fully exhale and your epiglottis closes, you should have 5 centimeters of water of PEEP. So every patient we transport should get PEEP. So it's at 0 now. Let's set it for 5. And if you notice, you can only press that button and it goes up. It will go from 0 to 20 centimeters of water of PEEP. So an important thing for you to know is set the PEEP before you put the ventilator circuit on the patient, or you can encounter all kinds of problems and potentially damage lung tissue to your patient. Okay, so now we're fully set up in assist control mode. Let me explain a little bit about what that means. So this is a volume cycled ventilator, meaning when the patient triggers a breath, and it delivers a breath up to a preset volume, which we've predetermined for him and we set in the ventilator. And AC means assist control. It will give an assisted breath, meaning the patient can trigger their own breaths on the ventilator. They can breathe on their own. If they're breathing faster than 16 breaths a minute, that's fine. The ventilator will allow them to breathe faster than 16 breaths a minute. Their negative inspiratory force when they take in a breath will trigger the ventilator to give them the breath. Also, it will give a controlled breath, meaning if the patient's apneic, it will deliver that tidal volume, 600 milliliters, at 16 breaths a minute, with a 1 to 2 inspiratory expiratory rate. So if the patient stops breathing, the ventilator is going to breathe for him in a manner that we've preset. So there's some dangers, and there's some inherent dangers that you need to know about assist control. Most all the patients we transport out of the ERs and the ICUs are going to be in assist control mode. You need to make sure your patient is adequately sedated or comatose or comfortable on the ventilator when you put them in this mode, because what happens is if they start panicking on the ventilator, if they're uncomfortable and they start breathing more than 16 breaths a minute, say they start breathing 30 breaths a minute, as your respiratory rate increases, your tidal volume decreases. But what happens when the patient triggers a breath on the ventilator each time at 30 breaths a minute, the ventilator is going to try to deliver them the full 600 milliliter tidal volume. So what's going to happen is the patient's not going to have time to exhale the previous breath that they got, and it's going to blow up their lungs. It's going to create increased intrathoracic pressure, which is called auto-PEEP, or breath stacking. That can damage lung tissue. That's called barotrauma. It can also create pneumothoraxes. If there's too much pressure in the chest, it can press on their aorta and lower their blood pressure. When you have too much pressure in the center of your chest and it pressures on your aorta, if you remember your cardiac stuff, that will decrease their preload and also lower their blood pressure. So you may find if the patient starts overbreathing on the ventilator, and you may start to watch their blood pressure rapidly decrease and their heart rate increase. So that's bad. Another thing that can happen if they start overbreathing the ventilator in AC mode is hypocarbia, or they start blowing off too much CO2. That's bad, and there's a few reasons why that's bad. If you remember head injury patients, when you hyperventilate a head injury patient, it causes cerebrovascular constriction. So if you're transporting somebody post-cardiac arrest, or you're transporting a trauma patient and you want to protect their brain, you don't want reduced blood flow to their brain. So we don't want to hyperventilate them. That can cause brain damage. It can cause a stroke. It can infarct part of their brain tissue. Also, another thing that not enough CO2 can cause, or hypocarbia can cause, it can cause a respiratory alkalosis, or an alkalotic state in the body, which can do all kinds of physiologic bad things, including arrhythmias, cardiac arrhythmias. So if they get too hypocarbic or too alkalotic, they can go back into cardiac arrest, have VFib, VTAC, have all kinds of cardiac arrhythmias. So the important thing you need to know when a patient's on AC mode is they're comfortable. So when you set up your ventilator and you put them on it, watch them for a minute. Make sure they're comfortable. Make sure they maintain their O2 sats. Watch the respiratory rate. Make sure the respiratory rate doesn't climb high and they don't overbreathe the ventilator. If they do start overbreathing the ventilator and they become uncomfortable on it, there's a few things we can do. You can, if you're in the ER, ask that the patient be adequately sedated before you transport them. Don't be afraid to ask a physician for that. Ask them for sedation, or if they're intubated and they were awake before they were intubated, make sure they have a paralytic on board with sedation. So vecuronium, rocuronium, all those last. They're non-depolarizing paralytics, and they last for anywhere from 25 to 35 minutes. So make sure your patient's adequately sedated before you leave the ER or the ICU. If you're in transport, which we don't carry any sedation or paralytics, if you're in transport and your patient starts overbreathing the ventilator, something that you can do is take them off the ventilator and bag them. Bag them as they breathe. You don't want them to hyperventilate in this mode. So if they start doing this in transport, take them off the ventilator altogether and bag them. That's AC mode. All right. Bye.